So in the fifth international workshop on the biology, prevention, and treatment of relapse post transplant and cellular therapies that was recently held in New York on October 8th and 9th, there was a lot of sessions around that were very well attended and very interactive. And when we talk about relapse, a lot of people focus on relapse after allo transplant. So we had a full session focused on relapse after auto transplant, in which we had various speakers. The first one was Dr. Mary Horowitz from the Center for International Blood and Marrow Transplant Research, which gave a great overview of the scope of the problem. And if it's true that relapse after allo is the most important cause of treatment failure, relapse after auto is probably, it represents 90% plus of the causes of treatment failure. And, the interesting thing is that, 1 in 3 year survivals for patients who've relapsed after autos are not bad, but these patients are requiring multiple lines of treatment. So their burden of treatment after what should have been considered a strategy that would provide long-term disease control is significant. I think the bottom line there was a couple of things, that many strategies that are very effective for treatment of relapse after auto transplant, particularly second transplantations, are rarely utilized, particularly in myeloma. In the same session, we had Dr. Hermann Einzele present, data from the German randomized trial, which showed a benefit for second transplants in regard to progression-free survival and overall survival. Yet in that trial, 30% of patients who were randomized to receive a second transplant did not receive it, either because they were unable to collect enough stem cells or physician and patient bias. A lot of them, I think, focus of the discussion was the underutilization of stem cells that are frozen, that these cells could actually be used as boosts to be able to allow patients to get further chemotherapy. So I think the three themes of that session was, one, that there is life for patients who relapse after auto. Two, that there are strategies that could achieve long-term disease control. One is CAR T cells for lymphoma. The other one is second transplants for myeloma. And then finally, that these strategies are significantly underutilized. And that's a segue to your second question, which is, what are we doing to try to enhance access to CAR T or other cellular therapies? And this will become a national conversation, because we do know that particularly in lymphoma and myeloma, in lymphoma, where we have multiple commercial products and labeled indications available, these products are severely underutilized, partly because they require transportation to a specialized center and staying at the specialized center for 30 days. These are not off-the-shelf products. They're still personalized products that require the patient to donate cells, that those cells get sent to a manufacturing facility, and then they get sent back to the treating facility. So there's a lot of logistics involved, and they're also very expensive. So I think both the American Society of Transplant Cellular Therapy, the American Society of Hematology, the American Society of Clinical Oncology, and all patient advocacy groups recognize that access to these products is a significant issue. Transplant centers are trying to, or cell therapy centers are trying to make access easier by, providing residential solutions for patients who are not from the local area, partnering with local practices. We at Memorial Sloan Kettering have been very involved in shared care models with our colleagues at Hartford and Connecticut, and we're trying to establish similar shared care models for large practices across Long Island. And while we hope that these shared care models will allow us to give more access to patients to these cellular therapies, while at the same time minimize the burden of treatment and the time they have to spend locally.